Hello everybody. Today I'll be presenting on the topic Introduction to Composite Resin.
Today we'll be covering the following topics. Let's see what are composites. They are two or more chemically distinct materials which when combined have improved properties. They retain their identity in the composite, that is, they do not dissolve or merge completely although they act in concert. Moving on to the history and evolution of composites. Composite was introduced by Dr. Raphael Bowen in 1955. The concept of acid etching enamel was put forward by Dr. Michael Bonacor. The initial composite resin were superior than the predecessor, which was made up of silicate and polymethyl methacrylate. Contemporary composite resin were vast superior than the original material in both clinical performance and aesthetic potential. Let's see the indications of composites. It is used in class 1, 2, 3, 4, 5 and 6 restorations, core buildup, sealants and preventive resin restorations, aesthetic enhancement procedures, cements, veneering, metal crowns and bridges, periodontal splinting, non-carious lesions, enamel hypoplasia, composite inlays, repair of old composite restorations, patients allergic to metals, and temporary restorations.
Now let's look in detail about the contraindications of composites. Isolation. Composites are contraindicated in areas where the access and isolation is difficult as it causes adhesive failure and leads to inferior mechanical properties. Subgingival areas. There are two reasons why composites are contraindicated in subgingival areas. Point number 1. When restoring subgingival defects with composite, the supracrestal tissue attachment is violated, leading to surgical crown lengthening or extrusion of tooth. In order to avoid chronic gingivitis, tissue irritation, alveolar bone resorption, composites are contraindicated. Number 2. The gingival clavicular fluid might interfere with composite, thus leading to loss of adhesive property of composite. Poor oral hygiene and high caries index. Composite requires good oral hygiene for good bonding of the material, and due to its polymerization shrinkage, there will be marginal leakage leading to secondary caries. There is no additional advantage of microbial activity reduction as in GIC that releases fluoride, thus reducing caries index. It is contraindicated in habits like bruxism as the teeth encounters heavy or abnormal occlusal stresses. Operator abilities. Composites are tooth color restoration and highly technique sensitive procedure. It requires a skillful operator to accomplish good aesthetic restoration.
What are the advantages of using composites? They are aesthetics, conservative, less complex, used almost universally, strengthening, bonded to the tooth structure, repairable, no corrosion, no health hazards, cheaper than porcelain. Few disadvantages of using composites are polymerization shrinkage, technique sensitive, higher coefficient of thermal expansion, difficult and time consuming, increased occlusal wear, low modulus of elasticity, lack of anti-karyogenic property, staining, and expensive. The three main components of composite resin materials are resin matrix, filler particles, silane coupling agents, others like inhibitors and optical modifiers. The commonly used resin matrix in composites are bisphenol A-glycidyl methacrylate, urethane dimethacrylate, triethylene glycol dimethacrylate. It sets by polymerization reaction. The major advantage over methyl methacrylate is that The monomeric molecule is larger than the monomeric methyl metaacrylate, thus less polymerization shrinkage. The filler particles in composite resins are composed of quartz or silica that vary in shape and size. The incorporation of fillers into the resin matrix increases the strength and reduces the polymerization shrinkage. We need to keep two rules in our mind regarding filler particles. The more filler, the better. The smaller the average filler particle size, the better. The role of silane coupling agents is to chemically bind the filler particle to the resin matrix. Silanes are bifunctional molecules that have two different end groups, one of which bonds to the filler particle and the other to the matrix. It decreases the solubility and water absorption and increases the wear resistance and strength of composite. Salinization is complex and involves coating the particles with silane and utilizing acetone washes to thin the thickness of silane to monomolecular layer. In chemically activated composites, benzoyl peroxide is used as an initiator and aromatic tertiary amine is used as an activator. Polymerization. Heat, light, and chemicals causes decomposition of benzoyl peroxide that causes emission of free radicals. It is recommended to store in cool, dark, clean environment. It is used in restorations and large foundation structures that are not easily cured with a light source. In case of UV light-initiated, light-activated composites, benzoyl alkyl ether is used as an initiator. Visible light-initiated, light-activated composites uses camphor quinone photosynthesizer. In both these cases, polymerization occurs on absorption of light which emits free radical. The inhibitors used in composites are 0.01% butylated hydroxytoluene and 4-methoxyphenol. These extends the storage and the working time. These compounds are used in amounts of 0.1% or less. Optical modifiers. The metal oxides are used as pigments. Opacifiers like titanium oxide and aluminum oxide of 0.001% to 0.007% are used. These are UV light absorbers. They are darker in shade and the opacifiers are thin in layers. The dental composites are classified based on polymerization method, filler particle type, viscosity, and recently introduced composites. Based on polymerization method, we have light cured composites, chemical cured composites, dual cured composites. Based on filler particle size, we have macro-filled composites, micro-filled composites, hybrid composites, which comprises microhybrid and nanohybrid. Based on viscosity, we have packable and flowable composites. The recently introduced composites include low shrinkage composite resin material, silurine composites, bulk fill composite resin materials that comprises of flowable base and full body base bulk fill composites. Now, let's look in detail about each composites. The polymerization reaction for composites can be initiated chemically or with visible light. The chemical cure composite is also called auto-cure, chemical cure, or self-cure composite resin. They have poor long-term color stability and limited working time. They are used as a core material for buildup of extremely damaged teeth. Moving on to the light cure composites. They have infinite working length. Due to the elimination of tertiary amines, they are color stable. Less porosity, ease of manipulation, increased hardness and wear resistance of superficial layer. A wavelength of 400 to 500 nanometer is used. Now, let's compare light cure and chemical cure composites. In chemical cure composites, polymerization is central, curing in one phase, sets within 45 seconds, shrinkage towards the center of the bulk, no control over the working time, air may get incorporated, more wastage of material, not properly finished. Whereas the light cure composites, polymerization is peripheral, curing in increments, sets only after light activation, shrinkage towards the light source, working time under control, less chance of air entrapment, less wastage of material, better finish. The dual cure composites utilizes both light cure and chemical cure. It is used as cements or core materials. Setting time is initiated by exposure of visible light, but the reaction will continue over time in absence of light. According to the filler particle size, the macro-filled composite resin material has high level of loading of approximately 75% by weight with particle size between 4 to 40 microns. Larger filler particles resulted in two disadvantages. These materials were not polishable and they have poor wear resistance. The microfilled composite resin materials comprises of low level of filler loading of approximately 45 to 55% by weight. These have uniform filler particle size of 0.04 microns. They show excellent aesthetic results. They are unsuitable for stress-bearing restoration. They are contraindicated in class 4 and posterior teeth restorations. These are material of choice for restoration of non-carious cervical lesions. Examples: Silex Plus, Renamel, Durafil VS, and A110. The hybrid composite resin material is a combination of larger and smaller filler particles in order to improve the wear resistance and permit polishability. The filler content is approximately 75 to 80% by weight. The particle size is between 1 to 2 microns. Examples include Herculite XRV, Orange CA, Z100, and TPH. These are further described as microhybrids and nanohybrids. These are a mixture of small and smaller particles that provide excellent handling and aesthetic potential. These permit the formation of clusters of very small particles that reduces the surface area to ensure wear resistance. They polish to a very high luster and maintain over time. Example: Acetate X, 0.4, Filtex Supreme. The packable or condensable composite resin materials are hybrid composites to which large fillers are added that can be condensed or packed. These are similar to amalgam. Addition of large fillers causes poor wear resistance. Flowable composite resin materials consist of filler content of approximately 35 to 65% by weight. They are convenient to use. Since there is decrease in filler content, the physical property decreases. Therefore, there is increased polymerization shrinkage. The use of these materials must be restricted to nick functions such as 0.5 millimeters thick liner under large posterior composite restorations. Moving on to the recently introduced composites, the low shrinkage composite resin materials. Modern hybrid composites exhibits polymerization shrinkage between 2.2 to 2.4%. This amount of shrinkage if not compensated, causes contraction gap formation, micro leakage, post-operative sensitivity, and potential to develop recurrent caries. Recently, manufacturers came up with low shrinkage composite resin material with linear shrinkage between 1.4% and 1.7%. Decreased shrinkage of these materials has been accomplished by higher filler loading.
Silorane composites. They are based on silorane technology. They exhibit very low shrinkage and do not depend on increased filler loading. Siloranes are a class of composites introduced in dentistry by Weinman et al. In 2005. The term silorane is derived from siloxane and oxirane. The combined form of these two chemical compounds forms silorane, which is biocompatible and hydrophobic in nature. The polymerization mechanism of silorane composites is described as a cationic ring opening polymerization reaction that causes opening and expansion of polymeric chain. This reduces the volumetric shrinkage when compared to metaacrylate based composites. Bulk fill composite resin materials. They are introduced in order to divert from the incremental layering technique and reduce chair time. They decrease the polymerization-induced shrinkage stress and curing light penetration. They are used in increments of 4 to 5 millimeters. They are more translucent to facilitate light penetration. They are categorized into two: full body bulk fill composite that replaces both enamel and dentin, and flowable bulk fill composite that replaces only enamel.
Moving on to the generations of composites. The first generation composites consist of macroceramic reinforcing phase with highest surface roughness and good mechanical properties. The second generation consists of colloidal and macroceramic phases with best surface texture and wear resistance better than the first generation. The third generation composite is a hybrid combination of micro and macro ceramic fillers with a ratio of 75:25. It has good surface smoothness and reasonable strength. The fourth generation composite consists of hybrid and heat cured irregularly shaped fillers. The fifth generation composite is hybrid and consists of heat cured spherical shaped fillers with improved workability, surface texture, and wear resistance similar to the second generation. The mechanical and physical properties are similar to the fourth generation. The sixth generation composite is a hybrid with agglomerates of sintered macroceramics with least polymerization shrinkage and best mechanical properties. Here is a skeletal figure representing the generation of composites. The five manipulative variables with composite resin restorative materials are: the recommended thickness of an increment is about 2 millimeters. Curing sections more than 2 millimeters causes insufficient curing of the undersurface of the composite resin material. The light should be held in close proximity to the material. Closer the light, greater the irradiance, and should be exposed to a sufficient time frame. The depth of the cure is determined by the shade of the composite resin, the thickness of the material, the irradiance of the curing light, and the time of cure. The major deficiency of composite is the polymerization shrinkage between 2.2% and 2.4%, which results in microleakage, secondary caries, enamel crack, post-operative sensitivity, internal gap, and marginal staining.
Here are the 5 primary strategies that can be used to reduce the polymerization shrinkage stress. During cavity preparation, the C factor has to be reduced. Technique of build-up. Use a thin liner of 0.5 millimeter of resin modified glass ionomer or flowable composite resin as a liner under composite restoration. Use materials with minimal filler size. Light curing. Use of soft start polymerization that prolongs the gel phase of setting reaction of the composite. Use of modified composites like Silurian composites.
C factor. C factor is defined as the configuration of the cavity walls and is the relative ratio between the bonded surface area of the composite to the unbonded surface area of the composite. The higher the C factor, the greater is the potential for the bond disruption from the polymerization effects. A class 4 composite restoration has a wealth of unbonded surface area and a relatively small bonded area and thus has a low C factor. A class 1 cavity have a high C factor as they have a huge bonded area and a small unbonded area. Here is a tabular column explaining the C factor for each cavity. Now we move on to the clinical techniques of composite restoration. These are the following prerequisites that are required before composite restoration. Local anesthesia, preparation of the operating site, shape selection, isolation using rubber dam, gingival retraction cord, cotton rolls, preoperative wedging.
Now, let's look in detail about the hand instruments used in composite restoration. They are a set of 6 instruments which are Teflon coated. These Teflon coated composite instruments have the following characters. They are ergonomic design with fine grip handles. They have flat handle that apply less force on the tooth. They have curved beaks with fine working tip. They are ultra lightweight and tight grasping handles are present. They are corrosion resistant and autoclavable. Now let's look in detail about the individual hand instruments and their uses. The egg burnisher or beaver tail burnisher is used to blunt material for final contouring to achieve sculpting of areas like grooves, fissures or pits. The beaver tail burnisher is used for smoothing and polishing the surface or edge of dental restoration. Super plugger or rounded tapered cone burnisher is used for finishing and contouring the margins of the plastic filling restoration. Markley's plugger is used for finishing the margins of the restorative material and shaping the occlusal anatomy. Plastic instrument or plugger is a combination of medium-sized paddle-shaped blades for initial placement and small rounded condenser tip for universal adaptability. Ideal for placement, layering and general contouring. Plastic instrument or reverse angle plastic instrument is offset paddle-shaped blades for placing and shaping material on posterior, mesial and distal surfaces. Reverse angle is used for placing and shaping anterior bonded restoration. Cosmetic contouring instrument. It has a uniquely shaped blade at one end and has curved rounded paddle tip which is great for adding, sculpting and shaping composite material on desired facial areas of incisors.
Now let's see the different tooth preparations for composite restorations. Conventional design. Typical for amalgam restoration. Walls are in butt joints. Indications. Preparations located on the root surfaces. Moderate to large class 1 or class 2 restoration. Old amalgam restoration that needs to be replaced. Beveled conventional design. These are similar to the conventional preparation. They have some beveled enamel margins. The advantage of enamel bevel is that the ends of the enamel rods are more effectively etched, producing deeper micro undercuts than only when the sides of the enamel rods are etched. Indications. Restore large areas. Composite is used to replace the existing restoration, especially class 3, 4 and 5. Rarely used for posterior composite restoration. Modified design. They have no specified wall configuration, pulpal or axial depth. All parameters are determined by the extent of the cavity. The cavity preparation is conserved to obtain retention that results in scooped out appearance. Indications. Small, cavitated, carious lesion surrounded by enamel correcting enamel defects. Box only preparation. It is indicated only when the proximal surface is faulty with no lesions on the occlusal surface. Prepared with inverted cone or diamond burr holding parallel to the long axis of the tooth. The initial proximal axial depth is 0.2 mm inside the dentino-enamel junction. Neither bevel or secondary retention is required. Facial or lingual slot. Lesion is proximal but access through the facial or the lingual surface. The cavo surface is 90 degree or greater. Direct access of removal of caries. Points to be kept in mind while shade selection. Composite shade is selected prior to the rubber dam placement and prolonged drying of teeth because dehydrated tooth becomes lighter in shade as a result of decreased translucency. Samples from the shade guide should be applied parallel to the tooth surface whose color is matched. Not in front of it as it appears lighter, nor behind it as it appears darker. The natural light is preferable. Moving on to the steps in composite restoration. It is important to note that proper isolation is required for composite restoration. Proper isolation is achieved using cotton pellets, gingival retraction cord, rubber dam, and preoperative wedging. Acid etching is done for 15 to 30 seconds with 37% phosphoric acid. Thoroughly rinse it with water spray for 5 to 15 seconds. The surface is dried with cotton pellets or air. The etched enamel appears frosty white. Bonding agent is applied using a micro brush. Light cure it for 15 to 20 seconds. A mylar step is placed and composites are added in increment. Light cure it for 15 to 20 seconds. Finishing and polishing is done and check for high points using carbon paper. Hope the presentation was informative. Thank you and have a nice day.